Series of Docplexus KOL interviews, we have with us Dr. Biji Soman, who worked in the Indian Army as a major and was also trained in UK in cardiology. He is also currently working in a private medical college in Trivandrum. His area of expertise is extensive work on paternal cardiovascular diseases in women. Thank you so much, doctor, for this interview. So let's begin with the first question. So doctor, what made you focus on cardiovascular diseases in women?
Like once we came back to India and then I started working, we used to get a lot of lady patients who used to present with the so-called textbook atypical features, They would have chest pain which doesn't classically fit into the kind of cardiac pain which we are seeing. And in spite of reassurance or, giving them on medication, they keep coming back. And they were the kind of so-called low-risk patients. Yeah, and normally they say ladies in the reproductive age group, they have a low risk of developing coronary artery disease, and then the difficult part was to convince them that they don't have cardiovascular disease. So that's what led me into doing more work on the pattern on this thing of cardiovascular disease among women, more so in Indian scenario. Yeah.
So moving on to the next one. What is the difference that you find between the pattern of disease in men and women?
Abroad, what happens is you have a NHS system wherein the evaluation is more or less the same for the men and women, but in Indian scenario, we don't have an insurance or we don't have a national guidelines around. So these ladies, they kind of tend to get ignored. Most of them, they don't present to hospital, and even if they present, they go to the local doctor and they are reassured, or they said, you don't have a cardiac problem because you are having atypical symptoms. And many of them, even when they are put on medications, they don't continue it for long because here you have to pay for your pills. Okay, so so they stop their medications, and so you don't have a guideline-based proper treatment for these ladies. Then, like what we do for men, when you take ECG, there are abnormalities or they have an atypical presentation, you put them to treadmill, which is a non-invasive way of seeing whether they have obesity. And the strange thing is, a lot of ladies, they present with borderline positivity, or they don't have any conclusive, what we call it as inconclusive TMTs. So there again, we are not able to do a stratification for them. And then we had to look out for newer modalities. Then we looked into our patient load, and we found we were getting increasingly more female patients presenting with heart attacks or the myocardial infarctions. Right. Yeah, so that's something which is kind of scary, wherein the science says they are in a protected age group, or the risk of them developing coronary artery disease is less, but we have found that they still have, and world over their prognosis is bad actually. Even in the US, they come out with studies which has said female patients with cardiac problems, their outcome is much worse than for men.
Okay. So lastly, I would like to ask you, how do you evaluate this particular subset of patients?
What we have seen was not only females in the elderly age group, we used to get young ladies, okay, who have developed chest pains, and who even upon medication also they continue to have problems. So we did a study to find out what the pattern of risk factors. Like in India, you don't have females who do smoke or drink. We don't have those kind of people, but still they are having heart diseases. So we found out, there's a lot of element of stress, there is involvement of thyroid issues, and then a little bit of family history. And we found that, a lot of them are having cholesterol problems. They have dyslipidemia at a very young age. Okay. And then we put them to TMT, and some of them they have inconclusive, or some of them are positive on TMT, and there have been a lot of work on this. Then what has happened is, when we put them finally through a cath, we do a coronary angiography on them, and they don't have any major vessel disease. Okay, so it used to be like they used to be told that you have normal coronaries and you should go home and you should feel comfortable. But now a new entity has come as microvascular angina or non-obstructive coronary artery disease. Okay. So that's where our study was helpful, and what we do is we put them through cardiac MR, okay, and cardiac MR has this tendency to pick up ischemic changes, and it's non-invasive, so it can be used as a screening tool. May not be in a third world country like India because we don't have streamlined, and still we are paying, so cardiac MR are expensive. It's not easily available in all centers, but this is the way forward, you know. Just because someone is of a particular gender or particular age group, you may not, you cannot classify them as having a non-cardiac chest pain unless you evaluate them properly. The idea is to catch them early in the disease so that they can get proper treatment and counseling, and they have a better quality of life.
So thank you so much, doctor, for this interview. It was a pleasure having you here. Thank you so much. Thank you.